Hi, today I'll be talking about endometriosis. Endometriosis is a chronic inflammatory disease that affects the woman's endometrial lining, and it is uterine as well as extrauterine. And every month the woman suffers whenever the menstruation occurs. So you have the endometrial glands in between the myometrium known as adenomyosis and external endometriosis, where you have endometrial glands outside the uterus that affects the patient. So it can be in the bowel, it can be in the bladder, it starts at the uterosacrals, it can go further and affect the ovary, and that's how you have a woman who comes with the symptoms of severe dysmenorrhea and moderate dysmenorrhea every month. It's a cyclical pain. And you have women which comes with dyspareunia, and here you will find that the uterus is retroverted and it is fixed. There is nodularity on per vaginal examination if it is little advanced, and you will find that she will wince in pain when you do a per vaginal examination. Even rectal examination you can find those nodules, and if it is very advanced or a stage 4 endometriosis, as per the ASRM classification, you will find ovarian adenomas, you will have ovarian endometriomas, you will have ovarian cystic fluid filled with blood. So that can be unilateral or it could be a bilateral affection. Most of these women are found in the age group of 25 to 35 years of age, and they are having infertility. Previously it used to be said that endometriosis affects rich women, but now I have found in my practice that it also affects women who are multiparous, who are also about 35 years of age. It's not only a disease of a rich woman, but it affects the middle class, the lower middle class too. And the important point is that it will depend how you treat this patient, what is the age of the patient, what is her obstetric history, and what she comes with. So all these considerations will have to be taken by us when you treat the patient. After the history taking and basic examination, you need to do certain imaging technique and imaging modalities. Ultrasound plays a very important role in this particular pathology, and it will detect and also find out whether there is an ovarian endometrioma, and here you will find that there is a ground glass appearance of the chocolate cyst, what we call it. Sometimes it is bilateral and it is adherent to the posterior wall of the uterus, which we commonly call as kissing ovaries. So the rectovaginal plate also gets affected, and there is fusion there, and there is further advancement where it can go and affect the endometriosis in the bladder, in the bowel. So it's a deep infiltrating type of an endometriosis, and as the severity progresses, as per the years pass by, the woman suffers a lot and she has a very bad pain every month, and also the uterus can be globular, enlarged. She can have an adenomyotic uterus which is uniformly enlarged, tender. So all these things will have to be taken into consideration. Once we do an ultrasound, even an MRI may be needed. Sometimes this women also have fibroids. They have fibroid as well as endometriosis. So there are various theories of that. The commonly and the most popularly known is the Sampson's theory, that is the retrograde menstruation theory, where you find that the menstrual fluid enters back into the peritoneal cavity every month, and that also further causes endometriosis. You have immune dysfunction, we can have hormonal dysfunction, it could be estrogen dependent, and also it could be related to genetics and epigenetics, where there is release of cytokines, release of prostaglandins, and there is alteration and changes in the thromboxane A2 and prostaglandins, where the levels are affected, and then every month you have this cyclical pain and further progression of this disease occurs. So you need to halt the disease. Once you have done an imaging modality like ultrasound, you have done MRI, you need to map properly and understand the whole situation and go ahead to treat this patient. So there is a medical line of treatment, conservative line of treatment, definitive line of treatment, and a surgical line of treatment, which includes laparoscopy as the gold standard, and further definitive management with laparoscopy can be done. So laparoscopy is seeing and it is believing. What you see, you believe, and you go and treat it. So you see and treat it. So you don't just take a consent for the diagnostic laparoscopy. You need to take a consent for also, proper evaluation of the definitive plan. So an operative endoscopy needs to be done also, and also you need to do the consent for the diagnostic laparoscopy. So you find out what best has to be done to the patient. A proper counseling, proper explaining to the relatives, to the husband is very important, because once she is under anesthesia, she should know what you are dealing with. So it is very important that the counseling has to be done, and then you have to go ahead and do a laparoscopy, see that there is an endometriosis. It could be a different color, which is usually blackish or brownish color, endometrial glands which are like seedlings and the uterosacrals, or it could be more into the ovary or into the endometrial surface. You need to burn those, you need to cauterize those. You can use thermal energy, and with a monopolar cautery you can pinpointly burn them, and that will help to reduce her pain. Further, if it's an ovarian cyst, you should know where you are dealing with. A cystectomy needs to be done. The ovarian capsule has to be cut open. The cyst wall has to be separated from the ovarian tissue, and en masse you try to remove. There is a possibility of spillage of the blood, which is the dark black colored chocolate fluid, what we call as a chocolate cyst, that needs to be removed. And once you remove the cyst, you have to see that the core and the bleeding points are absolutely cauterized. So a proper lavage, a proper suctioning has to be done following this procedure, and hemostasis has to be achieved. We can see that the magnification is 10x. So even a small bleeder is magnified here. So you don't need to cauterize to that extent, because the more you use the thermal energy, the more the ovarian reserve is going to go down and the AMX level will go down. So you have to understand the situation, and if this patient is infertile, less amount of thermal energy has to be done, and a proper plain dissection and removal of the cyst, and then removal through the bag or through a proper way, so that there is no further spillage, has to be done. A good lavage, a good hemostasis should be achieved at the same time. If she has severe adenomyotic uterus and she has completed a childbearing age, you can do a definitive treatment and give her an option for a total laparoscopic hysterectomy with conservation of the ovary. And if of course she is more than 45-50 years old, and further any you need to do a definitive management. So all these things has to be done with proper consent taking and explaining to the patient. You have to do a conservative line of treatment and a fertility management of treatment for infertile patients and young patients. And if it is a severe or an advanced endometriosis involving even the sigmoid colon and the plane being adherent at the rectovaginal plate, then a proper multidisciplinary approach has to be taken. You cannot do it alone. You need to have a gastrosurgeon. You need to have a person who will dissect out properly. Even a shaving of the bowel might be needed, and all these things have to be taken into consideration and explained to the patient. So this is what is about endometriosis. I said what is a basic endometriosis and an advanced stage of endometriosis. I hope you liked my podcast, and I'm sure you will join me in the future. Thank you so much. Thanks to Science Integra, Times of Gynecology, for taking me on this platform and doing a video podcast on the subject of endometriosis.